Dr. Garros is a clinical professor of pediatrics, Division of Critical Care, and clinical professor at the John Doster Health Ethics Center at the University of Alberta. He's been a staff pediatric intensivist for more than 20 years at the Stollery Children's Hospital. His research interests are moral distress, end-of-life care, and supporting healthcare professionals, palliative care. He's volunteered internationally in South America, helping to support pediatric cardiac surgical programs. His background also includes bioethics training at Georgetown University and critical incident stress management training. Without further ado, I turn it over to you, Dr. Garros. Thank you.
Thank you, Michael, for this presentation. And for me, it's a real pleasure to be here talking to you and in my home institution at the University of Alberta and also at the John Dossiter ECMO Center, which I really, really value as a beacon of ethics in our province and in Canada. So it is really a pleasure. And by all means, I'm not a specialist on this topic. I'm just a curious person. And what I'm going to share with you is something that I've been, searching about and talking about with people and also with students for a while and residents. And I think there's not a lot there about it, but we'll try to see if we can come out with some ideas today. So what happens when we lose a patient? What are our reactions? Normal, problematic reactions? How should we express our emotions? Do we have emotions? Are we allowed to cry? And at the end, I hope that from this toolbox, I can give you some tips to survive and move on. And I want to do a disclosure here that many times I would say physicians, but I extend this also to all clinicians, which means nurses and allied healthcare professionals. So I'm not talking only about what physicians feel. There's a lot more on nursing on this area than there is for physicians. So in fact, that's why I concentrate a bit more on the physicians today, but this all applies. And I hope that people would forgive me if I talk too much about physicians, but I want to reiterate that this is for all us clinicians, okay? How to face a patient death to start this talk. So our grief, there's a lot written about nursing grief, but not a lot about physician grief. They regret the loss of a personal bond that they have developed with the pediatric, especially pediatric patients, some of for not carrying out their efforts to cure or control the disease, and others for an unresolved personal loss that arises with the child's death. So many times a child's death raises within ourselves some feelings that we never experienced before and brings out memories that we had from the past. But also important to realize that sometimes that also entails a situation where we see that the patient is a patient that we feel that maybe we haven't done enough or we didn't do enough. And there's this continuous fluctuation between experience the grief of focusing on the loss, but then avoiding or suppressing the grief, trying to move away from it. So that's a normal reaction that we face. And there are some healthy and adapted mechanisms that help the professional to make sense of the death of this patient. So these are something that we're going to talk about today, as well as the contribution to the care of the child and his family. So we are in this kind of a tossing between two worlds. The cost of losing a patient can be heavy. It leads to exhaustion, burnout, development of clinical psychiatric disorders, even including sleep disorders and the substance abuse. And what can happen to us all depends. Our occupational style, what our professions are, how do we carry on our profession, our own personality, but include also strategies focused on the problem and emotions that are surrounding this. And facing the event by contacting family members after the death is it's being demonstrated as an important step towards a healthy coping and avoiding burnout. So in our system, in our healthcare system, sometimes we are not supposed to feel this way. And what it does, in fact, it creates a real situation where we when we are not coping well with the death of a patient, what we do see is that we have increased absenteeism. We skip work, we decrease our quality of care, there are more medical errors, and there's decreased productivity. But at the personal level, there is fatigue of compassion or compassion fatigue that we're going to talk a little bit, exhaustion, physical and psychological symptoms, and decreased job satisfaction with this high level of distress. And this is from a beautiful article written, The Forgotten Mourners. And the staff turnover due to this decreased job satisfaction even increase. So that's something called disenfranchised grief. Forgive my Portuguese mixed with English. When the person who lives in mourning does not fit the socially accepted role of those who are expected to suffer from death. So in the views of people around us, in the views of the community, in the views of the lay people, we are not supposed to feel it. We are not supposed to have this mourning situation after we lose a patient. It doesn't fit this socially accepted norm from us. And we have this intrinsic into our being as physicians, as nurses, as physios, any other healthcare professional. We're not supposed to feel. So that's why is this disenfranchised grief. Expressions of regret are unacceptable. It's an unhealthy coping mechanism, is being said. And where this manifests the worst is when we have unexpected deaths, when there's death of young patients. I never forget a report from CBC, from one of the small centers in BC, when they interview a family doc working in an emergency department, and they're asking him, what do you think about when the patient die in your emergency department? You have seen a lot of deaths. And he said, yes, I've seen a lot of deaths, but I'll tell you one thing, I cannot cope with a child died. When a child dies in my department, that is the hardest part. So that's of young patients. Difficulty family situations related to that family whose child does die, or the adult who have died, the spouse or the wife. And then also what is worse on this problematic grief is when there is futile care and excessive treatment instead of a treatment that was proportional to what we think was the right thing to do. And this would makes us feel, not all of us, that's very important, not everybody, keep that in mind. Everybody's different. So just because we say that this will happen, is going to happen. No, people have different thresholds, different styles, different character personalities, but this can happen. Right? It making feel you in shock, in doubt, some withdrawal feelings, persistent thoughts related to the death, frustration, rage, even fault, repentance, inadequacy, and some experience acute stress reactions and post-traumatic stress disorders from a death of a patient. So you think you should have been able to see it coming, but when it comes, then you face this situation. But again, it's not for everyone. And sometimes we invite people to come for a debrief session, and we get upset that out of the 20 people that are involved with that case, 6 showed up. Well, some of them that did not show up, they are doing okay, and that is okay. And that's the nature of this. This is an interesting article on BJA talking about grief reactions and coping strategies of trainee doctors working PICU. pediatric critical care. And over a 12-month period, the most recent patient death that were involved, that was the question, how was it? And they look at the Texas Revised Inventory Grief and Impact of Events scale in 28 docs. 18% had severe emotional impact, 7% experienced severe grief, and CPR was a trigger of the worst reaction. And they did a quality analysis and they related prominent themes of sadness, helplessness, guilt, shock, and also very important, a concern for the bereaved family. And look at this. Speaking with another trainee doctor was the principal coping strategy, talking to a peer. And requests for debriefing sessions, greater psychological support, and follow-up with the patient's family were frequently suggested by the people that were surveyed. Are we allowed to feel? So what we do tend to focus is the last sentence. What did I do wrong? What did I fail to do? Where did I fail? And we know that we earn to have the skills of a good nurse or a good doctor that has the control of his emotions during the high stakes, emotionally charged situations. You want a kid, an adult that is crashing in front of you in the emergency department, in the ICU. You don't want a wimpy doctor or a wimpy nurse. You want a person that can handle the stress, handle that stressful situation. And we have people that work in this high technological environment with very, very, very sick patients. We thrive on this. It's like jumping from a cliff on a parachute. This is what we do for living. So we really focus to be the effective lead of the team, to be really a good nurse, a good doctor in these high situations. But we also experience loss in a humanistic way. We have to be, and we are humans. And the medical education has created an environment in which comforting families is essential, but showing our own emotion requires permission. Is that so? So, and this is a quote from an article talking about this. We need closure to the deep humanity of being a physician or a nurse is tested when we lose patients, especially those for whom we have provided care for years or even decades in our offices. The wounds we feel as part of these losses are helped by our efforts to stay connected with the family and by times of reflection about the patient we have lost. So part of a skill of being a good doctor, a good nurse that is a good lead that can control the teams, I hope, is also to be a human and experience the losses in a very humanistic way. I love this picture from Picasso in the early stages of his life when he painted this. And you see the two figures of the scientific side, the doctor holding the pulse and counting on his watch, but at the same time, the nurse giving the patient water and bringing the patient's son or daughter to be part of this disease or this situation, critical situation. This is reflective what the two scenarios that we live in our lives as healthcare professionals, the scientific side and the caring side of this situation. So many coping strategies exist, but many of them are maladaptive. Avoiding interaction with the patient's family, for example, avoiding caring for dying children in the future, alcohol abuse, drug abuse. Many doctors wish to speak to counselors, but few actually do so. They're more likely to talk to colleagues and consultants in an informal fashion on the cafeteria. Communication problems with the team or deaths occurring during night shifts may also hinder this because you are just going home and sleep and you are away from your team. So what can we do to each other? This is a beautiful quote from a general. Remember that in any man's dark hour, a pat on the back and a sincere handshake can work miracles. So we'll come back to that. Keep that in mind. How can I take this and continue to work? So this Just this last slide about these coping strategies. There's several ways to do this. One is the informational support, the exchange of information with the families and explaining everything that gives us solace. There's the clinical or instrumental support, the clinical collaboration to meet patient needs. There's the sharing of personal feelings and experience, the emotional support that we all need. There's the reflection and attribution of meaning to one's work experience. So meaning making support. And I'll come back to that. Opportunities for formal support, participate in support groups, critical incident stress debrief sessions, stress debriefing, supervision meetings. And there's also the informal support, the timeouts that we do after a tragic event in the unit. Those are all good coping strategies that we have to strive to have in our midst, if being in an office area, being in a hospital with acute care, being in a chronic care facility. Now, the big question is, can I cry in front of the family? And I think that's why many of you came here to hear this today, if I have anything useful about this. Can I sob? Well, very famous people sob and cry in very difficult circumstances. Why crying over a terminal patient may be a better doctor. Incredible article in the Washington Post that was written not too long ago. And what this article talk about is this: I'm not alone on this, but I know many doctors that do the same. They see our profession as cold, as indifferent. Many people do not see the way I see it. They see as professional as cold and indifferent. At the same time, they expect us to be strong. The media portrays the image of doctors driven by profit and who do not care so much about the people who are their patients, but we care. And our hearts often cry for our patients, same for nurses. We do this in private so as not to show weakness in front of patients. They need to trust that we strive to do the best for them. Again, going back to that skills and leadership that we think that we have to have all around. There's no other profession that has witnessed so much human tragedy and suffering. We all learn our own defense mechanisms to survive and continue our work. People need to remember that doctors are also human, and we worry, and our grief is very much. And this is an incredible testimony of an anonymous ER doctor that published his experience. And in the end, when the life went out of him and my hands could work no more, I left from that place into the night and wept. For myself, for life, for the tragedy of death's coming. Then I rose and walking back to the suffering house, forgot again my own wounds for the sake of healing theirs. And that is a picture expressing exactly this sentence. Do we actually know anything about this? Very little. This is a study from Australia about crying in hospital. 76% of nurses reported they cry in hospital. Not cry because they broke up with their boyfriend. They cry related to the job. 57% of physicians cry. 31% of medical students. And this is a large number of people that were on this study. And the primary reason for participants on the job crying was identification and bonding with the suffering of dying patients and their families. On Austria, a study in Austria showed emotional response of crying was fairly prevalent among 275 medical personnel and medical students study. And again, most often occur as an emotional reaction to dealing with dying patients. Sometimes we do this. We go to a corner and we cry alone. In Canada, study in medical students, first experience with the death of a patient, 29 studies, students, interviews, focus groups, or email interview. One pervasive theme, the tension between emotional concern for the patient and family, being a good doctor, a good nurse, still emotionally concerned for how this patient and how this family, especially now the family is doing, and the intuitive need for the professional detachment that we seem to need to have and carry on this feeling. In Denmark, another study in palliative care physicians and nurses, 347 participants. Physicians were more likely to leave the care of the dying patients to others, an avoidance technique. These themes center on uncomfortable feelings, grief, threatened control, and generally suppressed emotions. Why is it important to expose these themes? And one of the answers is we must attend to these feelings to avoid burnout. And there has been a good correlation between burnout and this kind of situations. An oncology study in Canada, researchers found that grief was considered shameful and unprofessional. So doctors in the study said that they wrestle with feelings of grief, but hid those feelings from others because showing emotion was considered a sign of weakness. And the researchers even reported the impact of the acknowledged grief was inattentiveness, impatience, irritability, emotional exhaustion, and again, burnout. There are some controversies, and I'm showing you the controversies. It is appropriate for a physician to display personal emotions in front of patients. One author in JAMA, 1994, already said this. Please, fellow physicians, don't cry in the empty rooms or stairwells or in lock-in rooms. Cry in public, and let the patients and staff heal you and see you are human. In the US, interviewed 65 third-year medical students in 2 schools about emotions about the patient's death. 32 interviews were examined. 57% of respondents rated the effect of patient death as highly and emotionally impactful. Interesting, that those cases in which the patient was cared for by the students' team, 63% indicated that there was no discussion by colleagues of the experience in the aftermath of the patient's death. It happened, nobody talked about it, they walk away. Are we prepared to deal with this? Feelings and attitudes about patient's death, another study, medical students, 1,400, 296 residents, 287 faculty. While the explicit frequency of bona fide grief response among participants was not reported, nearly half felt unprepared to manage their emotions about patient's death. In the USA, a study related to a recent death of an average patient that they portrayed there. 2 academic hospitals, 188 medical personnel, including students, residents, and attending physicians. The overall satisfying experience in caring for the dying patients was there, but on the Likert Styles rating scale, from 0 to 10, they found moderate levels of emotional impact. And the strongest emotions were felt by women and also by those physicians who had care for the patient for longer periods of time. Interns reported needing significantly more emotional support than attending physicians. So are we, as we get older, there's 2 possibilities here, my friends. Either more experience, we get into a situation of being more callous, more rock solid in the sense that we don't feel anything anymore, or we learn how to develop resilience and how to actually enhance our resilience with characteristics that we brought up from our background and our life as physicians. And the question is on the open. But look at this, discussing for the residents, discussing the death with the attending physician in 75% of the cases did not help them. They actually said that. So when we talk to our students and residents, we think that we're doing a good job. Maybe we are for 25% of them, but not for all of them. So where we go next? We work as a team of people that are in this together for the good, but for the bad. And in fact, think about a group of people that should never cry on the job. Those are the military, right? Even stronger feelings in the community that they should not cry. Well, I'll tell you a story. In 2004 in Baghdad, a platoon of the 1st Cavalry Division of the US Army was ambushed and lost 8 guys. There was the largest loss of life for the division since the Vietnam War. The colonel that was the commander of this platoon gave an interview. And he said, it's not about us, our guys, it's about the families. And he broke down in uncontrollable sobbing during the interview. And he was then horrified that he did that. And then he reported this afterwards. Colin Abrams, don't worry about it. It's a beautiful tribute to the man who died. This is when he reported back to his superiors. And this is the question. Was he letting the team down? Abrams wrote an email that day to his commander, General Peter Chiarelli. And General Chiarelli, very famous general, he said, I did an interview today and I let the division down. I got emotional and I'm so sorry that I let you all down. General Chiarelli wrote back to him and said, you would have let us down if you had done anything else. So these people are military on the highest ranking, showing humanism, compassion, showing they are human. Am I allowed to cry on my, regulatory bodies? Well, even the ACLS, the Advanced Cardiac Life Support, says physicians should not be afraid to cry when a patient dies. Crying is a healthy way to release and process emotions, reflecting what they knew about the patient and honoring their memory can be therapeutic. The Association of American Medical Colleges in 2019 review found that providers commonly experience moderate and sometimes long-term grief after patients' deaths. It is essential to acknowledge these losses rather than expecting providers to move on immediately to the next patient. So this is coming from very important regulatory bodies that are talking about allowing us to deal with this. What about our medical system? CanMed, the Royal College, there's an increased emphasis on physician health and well-being. The emerging concept of professional identity formation is woven through the professional role. Key competencies have been reorganized to reflect the commitment of the physician to the patient. Okay, so good. Clinical, directing to cure, directing to not harming, directed to make the patient better, to the society and to the profession. But look what the CanMeds also said. Apply capacity for self-regulation, including the assessment and monitoring of one's thoughts, behavior, emotion as attention for optimal performance and well-being. Look at career developing, career transition, commitment to disclosure of harmful patient safety incidents, all good. Mindful and reflective approach to practice, resilience for sustainable practice, and look at the other item. And this is subtitles of big paragraphs on the CanMed. Responsibility to self, including personal care, in order to serve others. So it is on our CanMeds to look at ourselves and look at improving our own well-being. And then there's the concept compassion fatigue. And there's a person from our ethics center, Dr. Wendy Austin, that has written a book about this. Is it that you feel that you have given so much, that you are so many times get into this emotion that you are exhausted, the physical, emotion, and spiritual exhaustion when caring for patients. You have an empty heart. The clinician with compassion fatigue can still care and get involved, albeit in a committed way. And that's from Dr. Austin's book. If you haven't read it, read it. Lying Down in the Ever Falling Snow. Canadian health professional experience of compassion fatigue. So we can get into this problem when we are giving so much to ourselves and we don't find an environment that can help us to cope with this. So I could talk just about compassion fatigue today, but we have to do something else. So let's talk a little bit at the end now of some strategies. How can we cope and how can we deal with our emotions, like little doctor there? So strategies, short term. We all hear about, yes, we need to do exercises. Yes, to do meditation, cultivating a spiritual life. Yes, we can write a diary. On long term, we can develop a personal philosophy of care. We have to engage in self-reflection and self-awareness. Wake up in the morning, look at the mirror and said, I am suffering with what's happening in the ICU or in my clinic with that patient or that family. What am I going to do about it? And commit to take care of yourself. And there's some personal things that we can do, it's some related to work. We have to develop professional supportive relationships that promote your division, your area, and enhance mutual support. And for support, you can trust your colleagues, and you have to trust your colleagues. And you should avoid family and friends for that kind of support. You can go home and say, I had a hard day, but don't expect that your wife or your husband or your companion, your son, your daughter will be able to understand the whole full spectrum what you're living through because they don't work on that environment. They can understand, and you should say to them, I had a hard day. We need to go for a walk. I have a difficult day. I need to go for a meal with you in a restaurant. I need to light a candle. Can you come with me? And that comes the concept of community of practice that Dr. Austin already wrote about as well. Someone to connect, to share, and someone that has an attentive ear, someone from the similar profession or same or similar profession, that we need to build support networks within our profession and find colleagues who would support us to take action to deal with moral suffering. And this will lead to more successful ways of achieving wellness. But we also sometimes have to speak with an authority voice. Assertiveness is so important when we feel that in our environment, with due respect, we need this space for us to share what we're feeling. Because sometimes these things that we're trying to feel and share at work are seen in a different way, in a bad way. And a common expression is if it is too hot in the kitchen, just leave the kitchen. I don't know how to say in a perfect English, but that's the meaning of it. So, you know that we can lose incredible professionals, skillful professionals, not because of lack of leadership skills and lack of good skills in terms of technical issues, but we'll lose them because they haven't found the support that they need. So we need to develop this communities of practice. It takes suspending judgment. It takes generous listening. It takes acknowledging the other person's feelings, validating their feelings, and then normalizing, saying, this is normal what you're feeling, and reframe those feelings. You can be honest about your experience and difficulties and give other permissions to void theirs. You seem anxious today. Are you okay? How can I support you right now? Validation of one another is so helpful. And the other sentence that we have to hear more in our work is, I really, really appreciate what you do. This speech is only beautiful when it's born from a long and silent listening. I did not learn it in books. I learned this by paying attention. That's a very famous writer, Brazilian writer, Ruben Alves, that said that. Some practical tools. One group decided in California to do not a code blue, another code blue, another code that we have brown in the unit, but they created the code lavender, code lavender. So code lavender is they created that delivers a healing basket with tea, lotion, and other calming products to anyone in need. And this came out of the mass shootings and fires and things that happened in their center that they were surrounded by in California. So they have on this room this moment of peaceful meditation. As you can see on the picture, everybody is receiving a free meal, everybody is receiving some teaching and receiving a basket, and that's a cold lavender. The pause. We just did this the other day in our emergency department when a 4-year-old girl, previously healthy, arrested at home for no reason. And we try incredibly effort by paramedics and ourselves in the emergency department to resuscitate her for 1 hour and 15 minutes. And at the end, we stopped. And we did the pause that was developed by Jonathan Bartels from the University of Virginia Medical Center. And we did this. 1 minute or 30 seconds of silence. And we said, we are going to take a break and pay homage. And then we said the name of the patient. She was someone who loved and was loved. She was a family or a kid of this lovely family. And she was someone's friend. In our own way, in silence, let us take a moment to honor her. And you can say the patient's name. And we'll also honor and acknowledge the team that provided this effort here right now. And then you finish. Thank you, everyone. If I had more time, I would have shown you a little video of one of these events. And this is being studied. And look at that, 79% of participants said the ritual bolster both a sense of closure and team connection, and 82% said it made them feel value for their efforts. And that's Jonathan Bartel, who had received a lot of accolades for developing this. Do this next time. Another tip I want to give you is what my good friend Cinder Rushton, a nurse from Boston, has written. Choosing how to respond to ethical challenges, dilemmas, and uncertainties in a way that preserves our integrity, minimize our own suffering, and allow us to serve with the highest purpose. So I highlight the words choosing how to respond because many times when we are seeing these situations of high distress in our ICUs, in our emergencies, in our clinics, we keep asking why this has happened, why we're leading to this, going to this path, and why. When we can look at the mirror in the morning and say, I'm going to choose to care for myself. And I'm going to be the best nurse, the best doctor, the best RT that I can do, that I can be today. That is going to be my choice. And I will, even though I don't agree what's going on, even though I'm suffering from the death of this patient that is imminent, I'm going to be there for them, for that family. And that way, you will preserve your integrity and you minimize your suffering, because there are things that we cannot change, but there are things that we can change. And one way to change is our reaction to a situation. And we want to continue to serve with the highest purpose And I want you to continue to serve with the highest purpose as you came to this job, fresh, no wrinkles, out of nursing school, out of medical school, with all the ideals in your mind to be a great nurse, a great physician. And I don't want you to give up. I want you to continue. But sometimes we have to make some choices. And this choice is going to preserve our integrity. And the final thing that I want to say is the importance of gratitude, affirmation of goodness. It's a source of strength. Appreciation is the ability to perceive positive events that occur in everyday professional life and not to take them for granted. Gratitude is not ignoring complaints, burdens, and hassle. They happen. We cannot ignore. But we have to look life as a whole. And gratitude inspires us to identify the good, even amid chaos, which was so typical during COVID-19. True gratitude would involve a humble dependence on others, an acknowledgement that others are higher powers if you're a spiritual person, if you have that belief. Gives us in ways that help us daily achieve the goodness in our lives. How many times we see the cleaning people in our hospitals looking at a room where a patient had just died, and we think that they don't feel it, that they are not part of it, but they are. So, what would be the good attitude? Not just then, but every day. Be grateful. Stop. Say thank you for what you're doing. I really love an attitude during my training from one of my mentors at Sea Kids. He would stop at the elevator and he will say thank you for the people that are coordinating the entrance of people at the bottom of the building. And after we finish our sign over as fellows, he will come out of the room and say, thank you, Daniel, for your work last night. And I would say, come on, that was my job. I'm learning. I'm being paid to do this job. That was part of what I'm supposed to do. You don't have to say thank you. No. That felt so important for us. And this is a letter to the editor on the Edmonton Journal a few years back when he had a comatose child that died at the Stollery, and the Supreme Court refused the parents' application for a court-ordered stay. And it was a difficult case. This tragic story of Babe M has been heart-wrenching to follow. And this was on the news. And this person, and I put publicly her name because it was on the newspaper. Now that this story has come to a conclusion for Baby M, my thoughts are with the healthcare staff who have cared for the child over the past several months. I cannot begin to imagine the difficulties and emotional turmoil for them. So society is in debt to them. And I hope they find some comfort in knowing their care, compassion, and courage have been thought by many of us who have followed this sad story. So we are not alone. And the public starting to see that we are vulnerable. we are still vulnerable and we're still humans, despite being skillful workers. So in conclusion, I want to say that we are human before we are clinicians. Little is known what clinicians feel, and I share with you some of the literature. There are adequate and ill-adapted responses all around, but we should have no guilt and no fear of showing our emotions. As I did today here as I was talking to you. As you can see, my voice got sometimes difficult to come out because I feel the emotion that this brings to us. How we solve this, we support with the support from colleagues and other professionals, with respect and compassion and humanism techniques at the time of that within our teams, our hospital, our environment, our clinics. And growing our well-being is so important, as the college has told us. And ultimately, we can cultivate a gratitude and all those good things that we talk about. I'm not afraid of storms, but I'm learning how to sail my ship. Thank you very much. And I'm open to questions.